All right, so thank you, Dr. Delaney, for that outstanding talk on EUE, and thanks for everybody for making it in today and having me back. It's good to see a lot of familiar faces from last year. And so we're going to move on. We're going to talk a little bit about probably everybody's favorite patient population other than Dr. Miller's chronic abdominal pain talk coming up, but gastroparesis. So obviously a very challenging group of patients that like to come back and see us frequently and can be very difficult to manage at times. So we're going to start off with no disclosures and then just briefly our objectives. My point with this talk is to try to keep things as clinically relevant as possible, so try to avoid as much basic science and getting down into the weeds. So I promise it will be a very brief review of kind of how the stomach works and how it should works, but maybe a little bit helpful for you all as you're trying to explain to your patients why they're having the symptoms they're having and trying to figure out exactly what's going on with them. Then we'll talk a bit more about gastroparesis and kind of what can cause this condition to occur, how to diagnose it, and then most importantly, kind of how do we manage it. And then we'll just have a few quick summary slides after that. All right, so to take everybody back to the classroom. So overview of kind of gastric neuromuscular signaling. So obviously it's a very complicated system. And what makes it so complicated is you have a multitude of inputs and neurotransmitters that can affect how it works, the speed at which it works, and things that can kind of throw it a little bit out of whack and start to give your patient symptoms. But overall, like most of the GI tract, you're going to have your parasympathetic nervous system fed by the vagus nerve, and that its whole job is to kind of speed things up, digest your food, move things through. In opposition to that is your sympathetic nervous system that's going to come into play with kind of your fight or flight response. And during that time period, whether it's from some external threat or just stress, that can kind of slow down the GI tract and give patients a variety of symptoms. On top of that, within the lining of the stomach itself, you have these very complicated cells, these interstitial cells of Cajal, and these are enteric neurons. So this is within the gastric cells themselves that are talking to each other and playing a role in how fast we digest our food when we start pushing food forward as opposed to just mixing it up. And then you have your smooth muscle cells, which are actually getting the work done, and that allows these coordinated contractions really throughout the GI tract, you know, whether you're mixing stuff, keeping it in the same location in the GI tract or starting to push stuff forward or backwards. And so what is the function of the stomach? So really it's pretty straightforward. So you eat your food, drink your liquids. Your esophagus' sole job is to get that food down to the stomach. That's where all the magic's going to happen. And so there's kind of four main things that it's going to do. The first one is going to be receptive relaxation. And a lot of that is going to come into play with the fundus, that top portion of the stomach there. And that's whole purpose is to take a stomach, which in its resting state should be about the size of your fist, and allow it to accommodate your meal at Chamagoucher or whatever other buffet you went to, where you definitely ate more than a fist worth of food. Its next job is to kind of create these recurrent peristaltic waves, really throughout the stomach, most primarily in the body and down near the antrum. And that sole goal is to take this food that you ate, that 16-ounce ribeye, and it needs to turn that into what's called chyme, which is just ground up liquid formulation of whatever you ate that your body's going to be able to absorb. After that, you're going to have the antral peristalsis, which again, the distal portion of the stomach, it's going to empty that digested or partially digested food into the small intestine for absorption. And then once all the nutrients are through, you're going to have these regular, slow, kind of migrating motor complexes, and their job is to just get rid of anything that's indigestible. So all that fiber we're telling our patients to eat, your leftover vegetables, it's going to clear all that through the stomach to take it back to that empty state. And so dysfunction in any of these roles of the stomach can cause a variety of symptoms, which we're all very, very common with dealing with. Nausea, early satiety, vomiting, and really dysregulation of gastric emptying. And so what should happen in what we consider a normal stomach? So really during that first 60 minutes after you eat, not a lot's going on. The fundus is relaxing, taking in that stomach, or taking in that food into the stomach, and really there's not a lot of emptying going on in that first hour. For the next 3 hours or so, now you're going to start to get these peristaltic waves that are breaking down that food. You're getting a lot of gastric juices being secreted, gastric acid, and you're breaking down all that solid food into a liquid formulation like we talked about. You're not going to start emptying your stomach until those little particles are about 1 to 2 millimeters. It's amazing that the stomach's able to do that and tell what's going on and wait till these particles are that small. But once they're that small and they're isotonic, then you're going to start to get emptying into the small intestine. And then again, like we talked about, you'll start to clear out whatever indigestible debris is left over. Liquids, on the other hand, are going to really empty on a linear pattern. So none of this will happen if your patient is just drinking a glass of water, for instance. A little bit more on the pylorus itself. So this is a very specialized zone of circular muscle with a couple different layers. And this is kind of the last barrier to food getting from the stomach into the small intestine. And again, like we talked about, multiple different inputs and controls over the opening of the pylorus. But anytime there's a dysfunction, whether it's letting stuff through too quickly or, in this case, letting stuff through too slowly, is going to play a role in how fast the stomach empties and subsequently what symptoms your patients are going to have. So we'll see this a lot in patients with diabetes, especially uncontrolled diabetes, if they've had surgeries in the past that may have damaged the vagus nerve. But we can also see it in patients with just chronic nausea and vomiting who don't actually have delayed overall gastric emptying, but they're just having kind of spasms of the pylorus. So we think this can happen from a couple of different things. One, it can be issues with the actual nerves controlling communication between the cells, those interstitial cells of Cajal. And so we'll see this a lot in patients who have had surgeries in the past, damage to the vagus nerve, where this muscle will just stay kind of closed and not let food through the way it's supposed to. And we can show that when we do various diagnostic modalities, such as manometry, which you'll probably never see or only done in a few kind of specialized academic centers. But they found that the smaller that pyloric diameter stays, the more symptomatic your patients are going to get. But a big one you will see is patients who are on chronic opiates. And they're, as you know, a lot of times going to come in with complaints of like early satiety and nausea. So what can happen if you're emptying food from your stomach too quickly? So this is a condition called dumping syndrome. It's much more rare than gastroparesis. But this is usually caused by somebody who's had a surgery that destroys that pylorus. So we're not seeing as much of that anymore. This would commonly be seen back in the prior to PPI days, where patients who had really bad gastric ulcers would get partial entrectomies, they'd lose that pylorus, and now food's just going straight through. You may see it to a lesser extent in your Roux-en-Y gastric bypass patients. What happens is the food rapidly passes through the stomach into the small intestine, and they can get a lot of GI side effects as well as vasomotor side effects. They may complain of diarrhea, bloating, nausea, vomiting, abdominal pain, but also usually they'll have some flushing, some tachycardia from these rapid shifts of food from the stomach into the small intestine. So there's some early symptoms with this, where you have this large food bolus that's not completely mixed up and isotonic, shifting into the small bowel, and you get a lot of fluid shifts, and the pancreas freaks out and spits out a bunch of insulin. Then you can also have late symptoms that now they have a lot of insulin, too much, they get a little bit of hypoglycemia. But these patients can come in and look very similar to a gastroparesis patient. It's just something to keep on your radar if they're like, oh yeah, I had a bad ulcer back in the 1980s, they took out part of my stomach. Maybe be thinking that stuff is passing through too quickly instead of too slowly. And now to kind of the purpose of our talk, what happens when it goes through too slow. So gastroparesis literally means paralysis of the stomach. We think there's about 3 to 5 million Americans who are affected by this in the United States today, and a higher proportion, up to about close to 2% of the population, that may have some delay in gastric emptying. It seems to be a little bit more female predominant. Usually we're seeing these patients in their early 30s, and the majority we see are going to be diabetic patients. Type 1 diabetes, we tend to see it a little bit more pronounced. Post-surgical patients on certain medications we'll talk about, and then a large proportion that we really don't know why they have it. But as you know from the patients you guys see in your clinics, it causes a significant drain not just on the healthcare system and all of our time, but also every time they're coming to see us, they're missing out on work days, and these are just the times they do come to see us. And so they're probably calling out much more frequently than that because it's a pretty miserable condition. This is something that's very commonly misdiagnosed out in the community. So one study looking at these patients up at Mayo Clinic, they looked at about 340 patients who were referred up there for a second opinion. And at the end of their testing, about 80% of them ended up having an alternate diagnosis. So even in these patients where it seems like a slam dunk, make sure you do your due diligence and diagnose them correctly. So an overview of gastroparesis, we're going to diagnose this not just by their clinical symptoms, but they need to have some objective delay in gastric emptying, and we need to rule out that there's a mechanical obstruction that's causing that delay. This can be done endoscopically or radiographically. The symptoms that we're looking for, we're all very familiar with. We see this all the time in patients who don't have gastroparesis: nausea, vomiting, early satiety after meals, feeling full quicker than they used to, bloating, and upper abdominal pain. So our favorite kind of constellation of symptoms to run into in clinic. And then the overall management, one, we want to make sure we're correcting their nutritional state. Two, we want to make sure their symptoms are getting better, because if not, they're going to come back and see us. And then maybe we're trying to improve their gastric emptying and control of their diabetes. So why does gastroparesis happen? Similar to a lot of these disorders in medicine or chronic pain in general, it's not really fully elucidated yet, and it's probably multifactorial. So we know they can get loss of these cells in the lining of their stomach that control the emptying, leading to some hypomotility. We know there can be a component of nerve injury, usually in our post-surgical patient. We know the stomach itself just may not be mixing and pushing food through the way it's supposed to, which we'll see a lot in our diabetic patient population. And then, like we talked about before, we think there's some issue with the pylorus allowing food to leave the stomach. Overall, the etiologies, about 40% of these are going to be idiopathic. I think a big proportion of these are going to be patients who've had prior GI infections. That's something you always want to ask if you have a patient who is doing just fine and now they're coming in with these symptoms. You want to find out, did you have a recent GI infection? Because we know the post-infectious population is probably a large proportion of that idiopathic patient load. For diabetics, really these are patients who have had diabetes for quite a while, usually about 5 to 10 years on average. Type 1, much more common than type 2, because again, they've had it usually since they were a child. And really we want to look to see if they have uncontrolled blood glucose levels. So in our clinics, really we're going to be looking at their A1C, and if you see they're poorly controlled, we can expect they're probably going to have some delayed gastric emptying. Our surgical patients, so we talked about antrectomy previously, but patients who've had a vagotomy, maybe for chronic pain issues, or if they've had a fundectomy from some other gastric lesion, bariatric surgery patients, very, very common. And we're finding more and more that these patients have a much higher rate of vagal nerve injuries than we initially thought. When it comes to your bariatric surgery, so your sleeve gastrectomies or fundoplications for anti-reflux, we actually see those tend to increase gastric emptying, but again, the symptoms may be similar. And then a smaller percentage which are obstructive, whether that's a mechanical obstruction from malignancy or spasms of the pylorus from opiate use. It's about 5 to 10% of these patients. Ischemic, very, very rare, and really we'll see these in patients who've been in the ICU for a long period of time, came in hemorrhagic shock. And then medications, probably one of our bigger ones. So GLP-1 agonists and analogs. Previously, we would just see them in the diabetic population. Now, I swear everybody's on one or trying to get on one. And so there's more and more data coming out on the GLP-1 agonists and analogs. But we do know that about half of them will develop delayed gastric emptying by 6 weeks. Half of those patients that do get it are going to resolve on their own, even though they're continuing the medication. But it's still a big percentage of patients who are on these that are going to have prolonged delayed gastric emptying. And then opiates, we all know the common ones to ask for, but don't forget tramadol can also slow down the gastric emptying. All right, let's go over our differential, because it can be very easy when these patients come in to kind of anchor on a diagnosis and not think of all the other things that can cause these very kind of non-specific symptoms. So functional dyspepsia, far and away the biggest ones. We're going to see way more of this than we are going to see true gastroparesis in our clinic. And there's two kind of different phenotypes. I know Dr. Miller will mention this in his talk briefly. But there's the postprandial distress, so those are your early satiety patients, and then the epigastric pain where they eat food, their stomach really hurts, and they come and see you guys. There's gastric outlet obstruction, something you never want to miss, whether it's from an ulcer, a mass, a bezoar that they ate. Accelerated gastric emptying that we talked about, medication side effects, again, GLP-1 agonists and analogs, far and away the biggest now, along with opiates. GERD, don't want to miss GERD, and you really want to get a good history, make sure they're not having a primary complaint of heartburn, because you can get some nausea and some early satiety with really bad reflux. Cyclic vomiting syndrome. For these patients, you really want to look for periods where they're asymptomatic, and then they will have 2 to 3 days up to a week of very severe symptoms where they're throwing up every day, and a lot of these patients are going to go to the ER when this happens. So if you see somebody coming in with this, I'm doing fine for 2 to 3 months, then I get these symptoms, I'm seen, and then I'm better after that, think of CVS. Rumination syndrome. So one big difference between this and gastroparesis, because again, they're going to come in and say they eat food, comes back up, and you're going to automatically think it's gastroparesis, but really this should occur daily with just about every meal for rumination syndrome. And what you really want to ask about is it effortless regurgitation, or they're eating, is the food sitting there for 30 minutes to an hour before they feel the need to throw it up? These patients are going to eat their food, within 15 minutes it's going to come back up. They're going to say, doesn't taste like partially digested food, it's just kind of effortless regurgitation. Cannabinoid hyperemesis. So for these patients, you want to look for a history of regular marijuana use. They have this kind of weird phenomenon where they tend to crave hot showers. Not specific for that, but it comes up on all our board exams. I've had like one patient ever actually talk about it, but it's out there. And then don't forget just eating disorders, especially bulimia with purging behaviors. So there's been a debate over the last several years with functional dyspepsia and gastroparesis, and whether or not these are two disorders that are on a very similar spectrum of disease, if not just gastroparesis is a more extreme version of dyspepsia. And this is because they have very similar symptoms, and we know they have very similar impaired physiologic processes. And so with these functional dyspepsia patients, they will come in and they will look at times just like a gastroparesis patient. They'll come in, they'll say they eat their food, they feel really full really quickly, they may throw up from time to time and feel really nauseous after the food's been sitting there a while. And so when they looked at these patient populations, they found that there was a large overlap in the ability for patients to kind of switch groups, where they would initially meet criteria for gastroparesis, but then later on, when they retested them 6 months later, be more of a functional dyspepsia, and we'll talk about the difference between the two when it comes to diagnosing them. And so we think there is some overlap for a certain percentage of these patients, and so when we talk about the diagnostic criteria, it's really important that you do the correct workup for these patients so they don't get labeled as gastroparetic and change their whole life around to try to treat it. So when we're diagnosing these patients, you really want to start with a thorough review of medications, get any relevant surgical history, look for the Memicurs that we just talked about. Then you need to rule out obstruction, right? So for us, being in GI, most commonly we're going to get an EGD, but if you don't have availability or the patient isn't too excited about that, you can get a CT or even a barium follow through and make sure there's no big mass in the stomach. And then, and most importantly, you need to get objective evidence that they are in fact have delayed gastric emptying. And so this is going to be your 4-hour solid gastric emptying study. There is a breath test, the Spirulina gastric emptying breath test, which is available, but not the gold standard. And then you may still see smart pill wireless motility capsule reports floating around. That company no longer makes them anymore, so going forward, it's not going to be an option. If you do get an EGD for these patients, you may get the report back that they went down there was retained food on it. While this makes it more likely they have gastroparesis, this is not diagnostic of it, and with a positive predictive value only of about 55%. So just over half of these patients who have retained food on EGD are actually going to have gastroparesis. Just as commonly as it being gastroparesis, it's going to be one of these other things, usually a medication. Again, the GLP-1 agonists and analogs. Over in the anesthesia world right now, they're coming out with a lot more data on how long these patients need to be off it. As of now, the recommendations are at least 1 to 2 weeks. So if you see your patients in clinic, they're on a GLP-1, whether it's for weight loss or for diabetes, typically you want them holding that dose before they go for their EGD. And then kind of the gold standard, the 4-hour solid gastric emptying study. So any patient, before I give them a diagnosis of gastroparesis, I'm going to get a 4-hour nuclear medicine gastric emptying study. And this, the reason it's such a big deal is it's a long study, right? And so people are going to find ways to kind of cut corners. And a lot of practices out in the community, they're just going to do an abbreviated version of the study. So they may do a 2-hour study or even a 1-hour study. And when they really looked at this, and they looked at a lot of community practices, they found only about 5% of these places were performing it correctly and meeting all kind of the quality benchmarks for this. But what your patient's going to experience for this is they're going to have basically a radio-labeled egg white meal that they eat, and they're going to get imaging at 0, 1, 2, 3, and 4 hours. And they're going to get a report that spits out how much of that meal had emptied at the different time periods. What you need to know for diagnosis is anything greater than 10% at 4 hours meets criteria for delayed gastric emptying and meets criteria for gastroparesis. There'll be a lot of 2-hour studies, but we know that trying to extrapolate the 2-hour time to 4-hour, it's not linear, and you're going to get a lot of false positives. Some limitations with this study: don't use it if your patients have had, Roux-en-Y bypass. This is just for patients with normal anatomy. They need to stop certain medications about 2 days before, so you're going to want to tell them in clinic off the GLP-1s for 1 to 2 weeks, but your opiates, laxatives, prokinetics, anything that speeds up the gastric emptying or slows it down, they need to be off for at least a couple of days. And then you need to let them know it's going to be a long test, so they're going to be there for 4 or 5 hours. The meal's going to taste terrible. They're going to complain about it to you. But we really need to get this 4-hour test before you give these patients the diagnosis. At least at our facility, they've been looking a lot at liquid emptying studies and seeing if there's any correlation between this and gastroparesis. And so we'll order a study and we'll get back a report that gives us a solid emptying test, but also a liquid emptying one. And this, just so you know, has no role in the diagnosis of gastroparesis. And so these patients, if they have a normal solid, it doesn't matter what their liquid is, they do not have gastroparesis. So in case you see that. The C-spirulina breath test, so basically it's similar to our SIBO breath testing where they eat the tracer, they get samples every 30 minutes for about 4 hours. What's nice about these is they can do it at home if they're able to get it available. It is FDA approved, and it's better than the wireless motility capsule that we were using, but not as good as the 4-hour test. This is what the wireless motility capsule looked like. So if you are looking through patient charts and you see a smart pill report, this is what it was. The patient would swallow it, and it would measure times as it goes through the stomach, small intestine, large intestine. And so we used it to look at gastric emptying times, but also colonic transit. No longer available, but just in case you come across a report, that's what it was. All right, some newer modalities, body surface gastric mapping. Really, this is maybe one day way down the line, this will be available in regular practice. Right now, it's just limited to larger clinics. Mayo, Cleveland Clinic are looking at this. And it gives us a lot more data about what's going on with the stomach, but not a lot of clinical relevancy yet. And then another thing that's getting more popular is looking at the pylorus itself. And so you can do a manometry, which again, only at a few research centers, or an endoflip, which if any of your practices have moved and started using endoflip for the esophagus, it can be also used for the pylorus, but we still don't have great data on how useful this is going to be. All right, so initial management. Far and away, the best thing you can do for your patient is going to be to get them to modify their diet. And so there were guidelines that came out, our most recent ones from the ACG were in 2022. And really, when you're talking to them about diet, they're going to want to know, what can I eat? What can I eat? Should I just cut it really small? Should I chew it thoroughly? Basically, you want them to be on a small particle diet and eating small meals throughout the day. So small particle, low fat, and what small particle actually means is it's a food that's soft enough to mash with a fork into small little pieces. So basically the opposite of what we're telling the other half of our patients, which is eat a lot more fiber and get a lot more vegetables. For these patients, they need stuff that's already going to break down very easily, pass through very easily, and not sit in the stomach for a long time. So we're avoiding high fat, high fiber. If they do really love their vegetables, the recommendations are to boil them thoroughly and blend it, which sounds terrible, but as miserable as these patients can get with their symptoms, they're kind of willing to try anything. For our diabetic patients, we know that once blood glucose levels are above about 180 to 200, even in a normal healthy volunteer, the gastric emptying is going to slow down. And so you really need to push them to get with their primary care and figure out a way to get their blood glucose levels under control. There's been a lot of promise with patients who are on continuous sub-Q insulin. Nutritional support, always we're going to want to push for oral intake, but you may have those rare patients that really cannot maintain their nutritional status, can't maintain adequate hydration with oral intake. And so those are the ones where you start thinking about other ways, whether that be a PEG tube with a jejunal extension or just a surgical jejunal tube. But start thinking about that if you have these patients that are doing the right things from a dietary standpoint and are actually not getting any better or getting worse. Once they're kind of getting to that point, start thinking about alternate ways to feed them. And then TPN is always going to be a last case scenario for us. But these patients, when they looked at it, they actually do really well on TPN with a 15-year survival rate of about 70%. Pharmacotherapy, so prokinetics is the one we're the most comfortable with. So right now, the only US FDA-approved medication is metoclopramide. There's a couple formulations. You can do the oral pills, 10 milligrams is usually what I'll put them on, sometimes 5 for certain patients. I'll do it TID before meals. There is a nasal spray available. I've never actually used it, but it is gaining in popularity. And we're always worried about the risk of tardive dyskinesia, right? We all learned in our pharmacotherapy classes that if these patients are on it for too long, they're going to get these horrible, irreversible side effects. We know now that the risk is very, very small, but if it happens, it's very, very dramatic, so it's still something to keep an eye out with. Domperidone, if you can get it, if you want to jump through all the paperwork loops to get it, actually works better than metoclopramide. Not available here without a lot of hoops to jump through, but doesn't cross that blood-brain barrier, so it does have the lower risk of tardive dyskinesia. And you do have to do a little, get an EKG on your patients before you start it. And then erythromycin is the other one that's commonly available. And for these, you can put it on it 3 times a day or 4 times a day. But usually after about 4 weeks of continuous use, your patient's going to stop responding to it and you're going to need to switch to something else. And so what I found the most helpful is to actually have them alternate courses of metoclopramide and erythromycin. And I'll do it for about 4 to 8 weeks at a time and then have them switch back to the other. Prucalopride, 2 to 4 milligrams. It initially showed some benefit, but in the diabetic patient population, which is a large portion of your true patients with gastroparesis, it doesn't seem that effective. Antiemetics, again, not improving their gastric emptying, but it will improve their symptoms. And at the end of the day, when you have these patients, that's often priority number 1 for them and up there for you as well. There is rectal formulations of phenergan, not that you should forget about. We used to use TCAs pretty commonly in these patients like we do for functional dyspepsia. The guidelines no longer recommend that. And then there's some other things down the line that are still not widely available, not FDA approved. And don't forget to stop the opiates. So additional management. Surgical interventions, they are available. Again, these are last resort in my mind for your patients. You can do it surgically, but we can also do some stuff endoscopically for these patients, including putting a stent across the pylorus, doing balloon dilations with the goal of stretching out the pylorus and making food empty a little easier. Botox injection was something we did fairly commonly up until a couple years ago when we started getting better data that says it doesn't actually help these patients any better than placebo. There is a GPOM, which is an endoscopic excision of the pylorus, basically, similar to what we do in the esophagus for our dysphagia patients with achalasia. It's very high technical success rates, meaning they can complete the procedure very well and seems to have some improved quality of life. But as of now, still only about 50% of these patients will have any sort of meaningful long-term benefit. And so for these, I would really try everything else before you consider doing that. And then gastric electrical stimulators, so approved as a humanitarian use device. And basically this, when I first heard about them, I always assumed it was stimulating the stomach and making it peristalsis a little better and push food through. It actually has no effects on their gastric emptying times, but it does seem to help their symptoms of nausea, which is what your patient's going to care about. There's some newer stuff coming out with kind of external vagal nerve stimulators that they actually apply to their neck using a little handheld device. Looks like it's going to replace these within the next couple years. Complementing alternative medicine, no great data for herbal remedies, electropuncture or electroacupuncture or acupuncture. No data for it, but if it works for your patients, it's not going to hurt them. A lot of social support groups, and then you'll see a lot of stuff online for like magnetic bracelets and things like that. No data behind them, but it's not going to hurt your patient if they want to try it. So this is just a brief summary slide straight out of the ACG guidelines, which I'd recommend downloading a copy and kind of glancing through. They're actually really good and straightforward and easy to read compared to some of their other stuff. But overall takeaways for these patients, number one, make sure you're giving them the correct diagnosis. We'll have a lot of patients that come in that have carried around this, being told they had gastroparesis for years and years and years, and then you actually do some testing on them and they don't have it, but in their mind they have it. I think there's something psychological with it as well. When you have a diagnosis like that it tends to make their symptoms a little worse, and they're more kind of hypervigilant, watching out for them. So make sure you're getting the 4-hour solid gastric emptying study. The vast majority of your patients are going to respond to dietary modifications. So again, low particle, low fat, avoid high fiber diets. And then don't be as afraid to use the prokinetics. I know initially starting off, you hear about Reglan and they're going to get tardive dyskinesia, and it can be a big barrier to prescribing the medication to these patients, when in reality, the risk is low and most of them are going to respond to it. And then keep surgery or other alternate forms of nutritional support as kind of a last resort. So that's all I have. Only a little bit over time, but